Welcome to the NWATC Project Echo. I'm Kent Unruh, and I'd like to turn it over to Christian Ramers to introduce our guest.
Great, thanks, Kent. We're very happy today to have Heidi Crane, a newly minted associate professor, who actually runs our metabolic clinic at the Madison Clinic and is kind of the go-to person with difficult lipid questions. So she's going to talk about dyslipidemia and HIV today.
Thank you very much. It's a pleasure for me to be here today. The first thing that comes up, of course, is why do we care about this? Why do we care about dyslipidemia and HIV? And one key reason is that the risk of cardiovascular disease among patients with HIV is higher. A number of studies have demonstrated that. One of them is from Kaiser, which showed that the rate of cardiovascular disease events was approximately 2 to 3-fold higher among those who had HIV than those who did not in an adjusted matched analysis. Another study that looked at not cardiovascular events themselves, but at a surrogate marker, carotid enamel media thickness, found similarly, the FRAM study found that having HIV, when they compared their HIV infected versus HIV uninfected men, that having HIV had almost as much impact on rates as smoking. So not just a small risk factor, but a very important risk factor. So why do we care about this? Because dyslipidemia is a key factor associated with cardiovascular disease. This has been demonstrated in any number of studies among the HIV uninfected. The Framingham study was one of the first to show that the associations between LDL and cardiovascular disease were important. Similarly, the Lipid Research Clinic cohort study has demonstrated this. So high LDL is associated with cardiovascular events and low HDL. More recently, and among fewer cohort studies, but still it's been demonstrated, even after taking into account the roles of LDL and HDL and other known risk factors, it's been shown that having elevated triglyceride levels are associated with cardiovascular disease. This is particularly important when in a minute we start thinking about what do the lipid levels or what do the lipid patterns look like among our patients with HIV. So let's talk about that for a minute. How does HIV dyslipidemia differ, or what does it look like compared with the general population? And I think we all can sort of recognize that it's really very different than the predominant LDL elevation that's often seen among HIV uninfected individuals. One of the first studies from the era prior to the antiretrovirals, done by Carl Grunfeld and colleagues, demonstrated that there was a decline, that patients who are infected with HIV develop a decline in total cholesterol, HDL, and LDL levels, and over time they then develop an increase in triglyceride levels, and this increase can be pretty dramatic, particularly later on in their disease course. A number of other studies showed similar findings. Then more recently, after we started being able to give patients antiretroviral therapy, what was seen is that with the initiation of antiretroviral medications, the total cholesterol and the LDL, not only do they return to baseline or increase, but often they go even much higher than the presumed baseline would have been at the beginning. Unfortunately, HDL, although it may increase with the initiation of antiretrovirals, it still often remains very low. And as I suspect many of us have seen, many patients then develop very high triglyceride levels. So again, we see a very different pattern than patients with HIV uninfected patients. We often see very high triglyceride levels and low HDL, and it's not the predominant elevated LDL level that's frequently seen. Getting more specific, when we talk about the impact of initiating antiretroviral agents, it's not just the sort of return to baseline, and it's not necessarily a class effect. When we talk about them, it's important to keep in mind that there are differences with the classes and that individual agents vary in their impact on lipid levels. So when we think about protease inhibitors as a class, we recall that in general, they increase the LDL and triglyceride levels, and that however, we need to recall that the least impact or the least dyslipidemic, if you will, is atazanavir and darunavir as well to some extent. Moving on to NNRTIs, these have a smaller increase in the lipid levels in general on average, and again, people can be very idiosyncratic, so this is on average. Some people have much greater and much smaller responses to these individual agents, but in general, the NNRTIs have smaller increases in some of these lipid levels. However, they also have a small increase in HDL that is not seen with the protease inhibitors. And then with the NRTIs, again, there's a spectrum of effects. All NRTIs are not equal. We're fortunate in that many of the worst offenders are NRTIs that we try not to use nearly as much at this point. And an example would be stavudine, as well as to a lesser extent danazine. One of the nice things that's been shown much more recently is that tenofovir, not only does it have the least dyslipidemic effect, but there's even a couple of studies that have been published in the last 2 years that show it may even have a slight lipid lowering effect, so very distinct than what has been seen with the other NRTIs. So given that, what is it we should be doing? What are the guidelines for screening and treating patients with dyslipidemia? In 2003, the HIV-MA and the AACTG got together and published a very nice set of guidelines on treatment and screening for dyslipidemia. First author is Dubé. And their main recommendation is essentially that we should follow the NCEP-ATP3 guidelines. So these are the same guidelines used for treating dyslipidemia among patients who do not have HIV. Their recommendation is that we check a lipid level, that we do a lipid panel at baseline, and then approximately 3 months after initiating antiretroviral therapy. Now, when we talk about these various guidelines, these are not the only set that are available, so there's some slight differences between the various guidelines. The ones I was just quoting are from the HIV-MA. There's also European guidelines. One of the few key distinctions between these various guidelines is that the HIV-MA guidelines recommend that you then calculate a cardiovascular risk score, such as the Framingham, on everyone who has 2 or more risk factors, while some of the European guidelines have been a bit more aggressive and suggested that we should be doing that routinely on everyone. In addition to what you do when you initiate antiretroviral therapy and baseline, a question is how do you follow them routinely? Dr. Aberg et al. Published a set of primary care guidelines for the management of patients with HIV, and their recommendation was that lipid panels should, as part of routine care, be followed every 6 to 12 months. So returning to the guidelines by Dubé et al., and clearly I did not make this slide. This is from that set of guidelines. This is their recommendations based on the NCEP-ATP3. And so you obtain a fasting panel, you initiate the antiretrovirals, you follow the patient up 3 to 6 months later. If their guidelines recommend if you have 2 or more risk factors, you then calculate a Framingham or similar cardiovascular health disease risk score and follow the NCEP-ATP criteria. And I'll show you what those cutoffs are in just 1 minute. And what you'll see here is that for the treatment, there's sort of 2 pathways that you end up with at the bottom. If you have an elevated LDL or moderately elevated triglycerides and therefore an elevated non-HDL, you end up on the left side of the chart. Well, if you have elevated triglycerides and don't have an elevated LDL, you end up at the bottom of the right. And the reason I point this out is, although this is from the NCEP guidelines, the non-HDL, LDL, etc., is from the HIV uninfected guidelines. What we see with HIV, as we mentioned earlier, is many more patients with these elevated triglyceride levels. So this is as well from the Dubé guidelines and from the NCEP for the HIV uninfected. And what you see here is the various cut points for where you should be initiating therapy. And as you can see, the more risk factors a patient has, the lower a score you use to initiate therapy. And the one thing, I suspect many people are familiar with this, so I won't belabor the point because this applies to HIV uninfected patients as well. But the one thing I would point out is that those patients in the top row with a cardiovascular, either with known cardiovascular disease or a risk equivalent, such as already having diabetes, those patients, while the initial NCEP-ATP3 goal was less than 100, there's been a pretty aggressive move to drop that down to less than 70, and that wouldn't be considered out of line. So you have a patient based on the prior chart that would benefit from treatment. How do you go about that? I think we all initiate and we all promote diet and lifestyle modification aggressively and frequently, although we're not always overwhelmingly enthusiastic about the results. So then once you have to move beyond that, what are some of the other options? And I've listed here the commonly used potential treatments for dyslipidemia, although I point out that the bottom one, the bile acid sequestrants, we typically don't use among patients with HIV because of concerns about decreasing the absorption of antiretrovirals. So that is one of the key distinctions between the HIV infected and uninfected treatments. So when you think back to that initial schematic where we divided the world into those with elevated LDL and those with elevated triglycerides, one of the most commonly used drugs is statins. That is the first-line recommendation for patients with elevated LDL or non-HDL. One of the things to point out is that they vary in their effectiveness, and when you think about many of the initial guidelines always recommended pravastatin as a first choice, and the reason for that was because it has the least amount of interactions potentially with other antiretroviral therapy. Unfortunately, it also has the least amount of effect on lipid levels. So when you think about them in relative scale of effectiveness, pravastatin less so than atorvastatin, and atorvastatin slightly less so, although not nearly as big a difference as rosuvastatin. Simvastatin and lovastatin typically are avoided among patients with HIV because they have dramatic and very bad interactions with the protease inhibitors. And I think one of the key take-home points is that the interactions with the statins and the antiretrovirals actually vary. So unlike some things where you can learn this by drug class, I think for the commonly used statins, there are specific interactions that have to be learned for treating with HIV. So when you think about pravastatin was actually hailed aggressively because it was thought to have less of the CYP3A4 based interactions, less of them than the other statins, and therefore it was commonly used despite its less effectiveness. More recently, it's been shown that efavirenz actually lowers the pravastatin levels, so not only is pravastatin less effective, at least with some regimens, you're even getting less than you think you're getting, making it less effective yet. A key point for patients now that we're using more and more darunavir is that actually increases statin levels, and so regardless of the statin selected, it's important to use it's important to start at a very low dose and to titrate slowly regardless of the statin you select. And atorvastatin, there's modest increases with the protease inhibitors, so again, starting with a very low dose and titrating is a reasonable approach. Initially, it was thought that rosuvastatin would be similar to pravastatin in terms of its interactions, and to some extent it is. It does not have the CYP3A4 mechanism-based interactions that some drugs have. Unfortunately, more recently, it's been shown that certain protease inhibitors, such as lopinavir, do increase rosuvastatin levels. This doesn't mean that you cannot use rosuvastatin with the protease inhibitors, but it does suggest that you should start at a low dose, lower than you would in HIV uninfected individuals, such as the 5 milligram as a starting dose, and you don't want to titrate up nearly as aggressively. On the other hand, rosuvastatin is so much more effective than the other statins that you typically don't need to titrate up aggressively. And then it's just not clear. There's a new statin, pitavastatin, which has the advantage of also not being metabolized much by the CYP3A4, so there is the hope that it will have minimal interactions with the antiretroviral therapies. However, it's early days and we just don't have the data to start using it yet, but we're hopeful, I guess. In general, when you think about statins, you can expect approximately, among HIV-infected patients, statins have approximately a 7% complication or side effect rate in that patients develop myalgias or myopathy or an elevation in CPK. Most of these are very minor, but that's a reasonable expectation in terms of thinking about how many patients aren't going to tolerate statins, how many patients with HIV will not tolerate their statins. So among patients that you've titrated up your statin as far as you can go, if you still haven't met your LDL goal, then the question is, what do you do next? Guidelines at this point would suggest I can never get this one, ezetimibe. I still don't say that one correctly. I apologize. Which works by blocking absorption at the intestinal brush border. This has a lot of nice features in that because it's an absorption drug, it doesn't have the same issues with interactions as all of the other medications. So there's a lot of reasons people like it a lot. ACTG A5029 was a study that demonstrated it had a mean additional lowering effect of LDL of approximately 21%. That was in a trial that added it in addition to stable doses of a statin, which is where we typically use it. So that was a very nicely done study that provided some very useful information. Unfortunately, the use of this drug over the long term is a little less clear because there were very disappointing findings from a recent HIV uninfected study that used this as an additional agent among patients with statin among HIV and uninfected individuals, and found that the results in terms of cardiovascular outcomes, which they measured by carotid intimal medial thickness reduction were really very disappointing. Some people have argued that this may the implications of the study are not yet totally clear, although the findings were clearly disappointing. However, there's been some have argued that because of the cardiovascular risk of the patients enrolled, it wasn't actually as well a done study as it had been hoped, and that we shouldn't be using that study to change our future therapy. I think the jury is not in yet on where this is going to go. And then I wanted to spend a couple of minutes talking about elevated triglyceride levels, because this is a good chunk of what we see. Guidelines suggest that fibrate therapy should be first line. Commonly used fibrates among HIV uninfected are gemfibrozol and fenofibrate. Now, when we're talking about patients with HIV, patients who are on protease inhibitors, that will actually impact gemfibrozol levels, so it's less effective. This may be one of the reasons why gemfibrozol is so much less effective among patients with HIV than patients without. However, it can't be the only explanation. There's certainly more going on than that. In addition, the fenofibrate clearly has less interactions with antiretrovirals, and has also been shown to have a lower rate, if you will, of rhabdo and other complications when given as an additional agent on top of statins than the gemfibrozol. So at this point, given the choice between the fenofibrate and gemfibrozol among patients with HIV, there's sort of a lot weighing it toward fenofibrate and not initiating gemfibrozol. A study that specifically did use fenofibrate among patients with HIV found that it had a 54% reduction in triglyceride levels. So this has really been shown to be the most potent thing we have when we're targeting triglyceride levels. Now, it's not the only thing that's available. Other options, either as a second agent or if patients don't tolerate the fibrates or aren't covered for insurance or whatever the numerous reasons are, we cannot use it. There's fish oil, which can be treated at a dose of 4 grams per day. People sometimes tolerate it better if you do that as a divided dose, for example, 2 in the morning and 2 at night. The nice thing about this is the lack of interactions, the lack of increase in statin toxicities, other factors. So it's got a lot of things recommending it. It doesn't have quite as potent an impact, if you will. It doesn't have nearly as much triglyceride lowering benefit as the fibrates do. A study by Wool and colleagues demonstrated that there was a 25% decrease in triglyceride levels among a randomized controlled trial. Again, some of these studies are a bit difficult to interpret because the higher the patients are who are enrolled, the greater the impact of each of these medications. So it's not actually entirely fair to compare study to study in this way. But that said, it certainly has less impact than fibrates, but a pretty substantial, nice benefit nonetheless. And it has the advantages of less interactions. Patients don't always like it. You'll hear they're potentially, much like in HIV uninfected, this is the same catfish breath, other less than overwhelming enthusiasm. There are things you can do. For example, if you keep it chilled, by the time it thaws, they've already swallowed it and it's gone, and they don't get the catfish breath. That actually can do a lot to improve tolerance. In addition, patients who tend to prefer more the supplement and like to avoid the pharmaceutical end of the world tend to prefer this and may be willing to take this when they wouldn't be willing to take another medication. And then the third potential reasonable option for elevated triglyceride levels, and it's always sort of listed here as third because it's much less well tolerated, is the niacin, even using the extended release. However, a study by the ACTG demonstrated that in that study, 70% of the patients who were enrolled were able to titrate up to and tolerate a full dose, and those patients received not quite a 40% decrease in triglycerides. So if patients tolerate it, it has a nice impact on the lipid levels, specifically the triglyceride levels, but it's not all that well tolerated. And it has an additional negative impact in that among some people it has a small increase in glucose levels. Specifically thinking about patients with HIV, we have one other option we can think about when we're trying to treat dyslipidemia, and that is thinking about their antiretroviral regimen and can we switch them to a less dyslipidemic regimen. Now, when we talk about these patients, dyslipidemia is not just from the ARVs, it's multifactorial, and there's this idea of return to normal that will be occurring regardless of the antiretrovirals. So we don't always get the benefit we expect. A couple of studies have looked at this and found that when patients were switched in an RCT from lopinavir to atazanavir, they did get a benefit in terms of total cholesterol levels, but it wasn't huge. Another more concerning study was a randomized trial where patients were switched from lopinavir to raltegravir, and that study was actually stopped early because they had an increase in virologic failures, pointing out that although we can get some benefit, we need to be careful not to cause more harm than good. And then just a couple of very cool things that have been published recently that may apply and be useful. One of them is an interesting article that's actually came out this week that showed that rosuvastatin has a much larger impact on changing LDL size to a less atherogenic phenotype, making it sort of less likely to develop atherosclerosis in terms of the type of LDL it is. Where this is going, it's very interesting, and we're going to, I think, see a lot more about differences in these various statins in terms of inflammatory pathways and other factors other than the direct impact on total LDL, triglyceride, and HDL counts. Another study came out very recently that actually showed a benefit of the diet advice in a trial. I just thought that was fabulous because we all do it, but none of us have ever seen anyone get better. There is a study that demonstrated a benefit. I love that one. And then I'm out of time, but I am going to highlight one more thing, and that's because of the long half-life with rosuvastatin, there's been a couple of studies in HIV-infected patients that showed among patients who didn't tolerate them because of myalgias, you can actually get away with these very low doses either every other day and every week, and patients tolerated them. So sometimes we can get a low dose of rosuvastatin in patients that wouldn't tolerate any other. So in conclusion, I think we need to remember that the dyslipidemia of patients with HIV is very multifactorial. We need to be screening for this routinely. We can't treat it if we don't know it's there. The patterns of lipids are both different from patients who don't have HIV as well as from patients who are not yet on antiretroviral therapy. Much of it we treat the same as HIV uninfected individuals, although there's some specific differences and we have to be much more careful of interactions. Rosuvastatin tends to be more effective than the others, although we have to use very low doses and be cautious when we're using it with protease inhibitors. When we're switching to reduce dyslipidemia, we need to do that cautiously. And stay tuned, there's a whole bunch of really interesting things going on right now that may change everything and have a huge impact over the next couple of years.